Hi, this is Brian Kim. I want to share with you this case of a patient who has a dense cataract and a small pupil. And so, as you've known with my videos, I like to perform double chop, cross chop mechanical fracturing in cases that have small pupils and fairly soft lenses because I'm confident I can disassemble these lenses with those maneuvers using mechanical forces, cutting the lens with the instruments and then hooking the lens from the equator and pulling them up out of the bag. But for the dense cataracts and with cases of zonulopathy, I do think a pupil expanding device is better. And in my case, I like to use iris hooks instead of a ring. And so you can see this is the corneal marker, which will help me center and size the rhexis. I'm making my paracentesis incisions, but I'm also going to make my incisions for my iris hooks. So those are my cataract incisions right there. And then I'm going to strategically place 5 fairly equidistant incisions at the limbus for my iris hooks. I place 4 paracentesis incisions and then 1 subincisional episcleral incision. Again, I'm still parallel to the iris plane, and so this incision is also a self-sealing incision. So this is intracameral lidocaine and then some intracameral epinephrine. And then before I place any viscoelastic in, I go ahead and place my iris hooks. I'm using 2 forceps. You go in and then twirl the hook with the stopper there and then position it. And so place it in, rotate it, and then you hook it and then push the stopper down. The good news about these hooks is they're reusable, and so that's another reason why I like them. You're also getting support at the level of the sclera at the limbus. If you have a ring, there is no other support except the ring is supporting within itself at the level of the pupil. And since the iris is a mobile and floppy structure, it's just not as stable as securing the iris to the limbus. And so those are the 4 iris hooks that I've placed. And I believe I'm going to wait on the 5th hook until I make my incision. So here I go ahead and inject some TriPlanar blue with a small air bubble here. There you go, there's a little bit more of a bubble there. Yeah, I'm having a little bit of trouble with the cannula. So now I'm going to paint the TriPlanar blue on the anterior capsule surface, dripping it and also massaging it in a paint roller effect. So now this is the dispersive viscoelastic to push the TriPlanar blue as well as the bubble out. And this is the TriPlanar corneal incision. I make a vertical groove, place the blade into the deep part of the groove, tunnel, and using the cannula, I'll turn the eye a little bit towards me and then I'll enter. So I made my incision first, push some more viscoelastic in, and then I'm going to put that final iris hook. And it's going to go into the episclera, so it will not really interfere with any of my manipulation at the level of the corneal incision. So I'm having a little trouble finding the place that I made the episcleral stab incision. Oh, there it goes, I found it. Extending the stopper away, pointing it down, and then securing it. And so this way, I will not have any iris prolapse during the case. I'm injecting some more viscoelastic, and because these dense lenses and small pupils tend to have weak zonules, I go ahead and go straight to the cystotome, cut through the capsule, and then I pull down to create a little bit of a flap. And then I go in with the teeth sideways and then grasp the flat and go around circumferentially, trying to get a well-centered and sized rhexis. So far, no major indications that the zonules are weak, but based upon my experience, these do tend to have weaker zonules, and so I'm just, out of an abundance of precaution, taking these extra precaution steps. So finish off the rhexis, remove that little bit of capsule that's in there. And this is the capsular fornix hydrodissection technique. I place the cannula under the rhexis edge, contra-incisionally, point the tip down, get a nice wave, and then I'll gently decompress. You can see how much the lens moved when I did that maneuver, and so that does suggest some zonular laxity. I point the tip down on the right and hook the edge of the lens, and it begins to spin nicely here. Irrigate the surface of the eye, lift the incision with the chopper going in with irrigation off to minimize Descemet's trauma, removing the surface epinuclear material, placing the chopper under the rhexis edge contra-incisionally, the phaco tip vertically sub-incisionally. I'm going deep into the lens material, cutting it and crushing it as I'm bringing the instruments together, separating the lens pieces, and now you can see it's fully bisected, placing the chopper under the right heminucleus, pulling it centrally toward the phaco tip, and cutting that right heminucleus in half. So that is a double chop and cross chop. Using some vacuum to hold that first quadrant, lifting it up with some vacuum, and then crushing it in half, trying to emulsify those pieces, using a little bit of vacuum to grab it first, crushing the pieces between the instruments, and then emulsifying the smaller pieces there. I'm always ginger with my foot pedal control when I'm emulsifying the lens pieces. I never really go pedal to the metal when I do the emulsification. I like to flutter my foot pedal to minimize the ultrasonic energy there. So I place the chopper around that second quadrant, pulling it centrally toward the phaco tip and dividing that second quadrant, using some vacuum to grab that piece up. And you can just sense that with these dense lenses with some weak zonules, the pieces just are kind of interdigitated. They don't really want to come up. And so it just takes a little bit of effort, use a little bit of vacuum to grab that piece up. Again, it's such a big piece, and so I'm being careful, making sure I get around the lens pieces, crushing it, and then dividing the lens pieces, and then emulsifying the lens pieces. So you can see how stable the iris is, the pupil edge is when I'm having the iris hooks in place like that. Now that I've performed the initial chop, I'm bringing the sleeve down a little bit closer towards the tip. And this is important because it keeps the infusion, the fluid, irrigation fluid, closer to the tip. So grab that piece with some vacuum, pulling it up, and then crushing it between the instruments and then emulsifying the lens pieces. So now we've essentially removed half the lens. I'm going to turn the second heminucleus in front of me very carefully here with minimal zonular traction, placing the chopper around the lens piece, placing the phaco tip fairly deep in the bag, making sure I'm getting around the girth of the lens, feeling the pressure, and then crushing and dividing the lens pieces, placing the chopper around that third quadrant in a similar fashion, getting around the equator of the lens, hooking the lens. Actually, I'm not quite sure I got all the way around it, but maybe good enough here. Start to separate the pieces, and then using a little bit of vacuum to try to get after the fragments there. Again, crushing the pieces into smaller pieces, and then emulsifying the lens pieces. And again, because of weak zonules, you don't want to really be emulsifying and using high vacuum near the posterior capsule in these cases. I really don't trust the posterior capsule in these very dense lenses because the posterior capsule can fly up towards the phaco needle during usage of high aspiration and vacuum. So I placed the chopper around the fourth quadrant, hooking the lens and then crushing it in half and sandwiching the lens pieces, using some vacuum to grasp that fragment, and then getting around it with the chopper and crushing it and dividing it, and then emulsifying the lens piece. I'm going to try to get after this last piece, getting the instruments around that piece and then crushing it. Separating the pieces. You can see there's a little bit of leatheriness to the lens pieces because of the density of the lens. And then emulsifying the lens pieces. When you have the lens last pieces left, you want to be very mindful about the posterior capsule. Watch your fluid, making sure you have a nice deep chamber. Don't go after pieces with vacuum. That's when you get into trouble because you don't have anything buffering between the phaco tip and the posterior capsule here. So just very carefully, just with mechanical manipulation of the lens pieces, I just manipulate the lens around the instruments and then crush it. And once I've crushed it into smaller pieces, I'm more confident it's going to be emulsified. I can keep that chopper deep to the phaco tip and protecting the posterior capsule. So here I'm removing the little bits of epinucleus here, which come out real nicely here. So that's it. So I take the chopper out, push BSS in, take the phaco tip out, and I go in with the INA handpiece. I start sub-incisionally removing the cortical material, sweeping side to side very slowly and gently, and peeling that material off. Again, I'm just using foot pedal modulation, making sure I don't grab the posterior capsule when I do this maneuver. Switch to polish mode, polishing under the rexus edge, partly because a lot of this is a blind maneuver. Again, because I assume the zonules are weak, you don't want to go after the lens material blindly with high vacuum. So you kind of switch between polish mode and cortex mode depending upon what you need to do. If you see a big piece, you can switch to cortex mode. If you're polishing blindly, you want to switch to the polish mode. So once it's nice and clean, I'm going to go ahead and pulse into the subincisional space with the cannula, making sure there's no more lens material there. There's a little bit of lens material there that's coming out. Go after it with the INA in the polish mode. And I can also go after it with the sweep if I have to. So push some viscoelastic, cohesive viscoelastic to fill the capsular bag. And this is a capsule sweep. I'll polish underneath the rexus edge on the left side here. And then on the right side. You can see by having that subincisional iris hook, it's just very advantageous. I'm able to do the case confidently without worrying about grabbing the iris with the phaco tip. So since this is going to be a three-piece lens, I have to widen my incision. So I widen my incision, and this is now the three-piece lens. Because I make a shelved incision, sometimes the injector gets snagged on the lip of that incision. And so when that happens, some viscoelastic can come out. And so I use that viscoelastic cannula. I want to push some more viscoelastic to inflate the capsular bag before I advance. And so I think here I'm asking for another tube of cohesive viscoelastic. So we go ahead and push some more cohesive viscoelastic, make sure the capsular bag is completely filled, and then I go ahead and proceed with delivering the 3-piece lens. I turn the bevel to the left, make sure the leading haptic goes into the bag in a planar configuration. The optic comes out. I have to rotate my hand 90 degrees counterclockwise so the optic comes out planar. And then I'm going to deliver the trailing haptic into the bag with the Maltzman instrument here. So I like the 3-piece lenses in cases of potential weak zonules. I feel like there's better equatorial support. I go in with the irrigation off with the INA, activate irrigation, and then I go underneath the lens, removing the viscoelastic from within the bag. Of course, because I've widened the lens, my chamber is not going to be nearly as stable, so I have to be very mindful about that with these manipulations here. Just want to make sure this lens is nice and centered. And so I'm kind of trying to turn the haptics a little bit to get a better center lens. I really think there's some asymmetry in the capsular bag. I don't think it's perfectly round and symmetrical, and that's why sometimes, even though your rhexis is perfectly centered, sometimes the lens is not well centered in the bag. So a small little nugget as I was doing that, so I was able to emulsify that small piece. All right, so that looks like a little bit of a better IOL position now that I've rotated it. So I'll go ahead and switch to viscoelastic mode. Remove all the viscoelastic from the anterior chamber. I'm going to push BSS in as I go out, and then I'll hydrate my incisions. Once the eye is stabilized, I have to remove all those hooks, and so we'll go ahead and remove them one by one. So I use a forceps two-handed technique to hold the stopper and hold the hook on the distal side just underneath the stopper, pull the stopper up, and then release the hook, turn it, and then pop it out. And once you do a lot of iris hooks, it's really quite quick and easy to do this. And again, if you get snagged, you just kind of have to twirl the hook using the stopper to do that. Just grab the stopper and then the hook just underneath it, pull the stopper up, pull it in, and then disengage, and then twirl it, and then pull it out. So go ahead and hydrate the incisions, and this is the end of the case. So again, this is a fairly dense cataract. You saw double chop, cross chop, mechanical fracturing techniques using the iris hook to retract in this small pupil dense cataract. These cases do tend to have zonulopathy in my experience. Always placing that subincisional iris through the episclera is also very helpful as well. So I hope this was helpful to you, and I thank you for your attention.